Very good evening to all of you. Please confirm you are able to see and hear me. Hello? Hello?
Hello, sir.
Yes, sir, we can
You are
able to
able to
hear
see
you.
and hear me, right? Yeah.
Yes,
Okay.
sir.
So welcome to yet another grand rounds to all of you. See, this particular grand rounds is to address a particular question, okay, like that we keep coming across. A lot of people actually want to start full-fledged vestibular clinics. They want to know what exactly is a full-fledged vestibular clinic is about and what is the advantage it brings to the patient, okay, to the patient or to our clients. Like what exactly is the advantage of having a full-fledged vestibular clinic. So far, the focus has been at reaching a diagnosis, and then after reaching a diagnosis, what was is a big question that keeps coming into our minds. Like, okay, if it's drug therapy, yes, what kind of drug therapy, and even in diagnosis, like what is the best way to reach the diagnosis. So far, when it comes to vestibular practice or the kind of setups that are there. Okay, the orientation is more okay, has been towards what I call as a vestibulometry. Okay, to a great extent, this is true. There are clinics which are exceptions, okay, which are doing very huge amount of great work, but there are also a lot of places where it is about the the emphasis is on metry. Metry simply okay, and most of the time it is a few numbers and then some what can be considered as jargon, and that is it. And then after that, what exactly needs to be done to the patient or what that means to the patient is not known. What do you achieve by telling there is a 33% okay canal paresis or 50% canal paresis? After that, what? So there has been a lot of emphasis on numbers, and then for some reason, okay, beyond that, though there are people who are doing great amount of work, okay, that is not percolated to the community like what exactly needs to be done. In fact, when it comes to ECG versus the metry, vestibulometry, okay, there is a significant difference that one of my professors, Dr. R.S. Mudhol, pointed out to me. When it comes to doing an ECG, people know, okay, this is the thing, there is an arrhythmia, there is no arrhythmia, okay, there is probably an ischemia, there is something, and then there is something actionable then and there. Okay, however, there has been something called ENG for many days, many years. Okay, there used to be this thing. Okay, there used to be rotary chairs for okay, about a century now. So many things have been there, but unfortunately, the kind of value that ECG gives, these graphs have not been giving. Okay, the reason I blame is on the approach called as a metry approach, about an approach called numbers. Today I was reading an article by Kurtais, and I was very glad to see one particular point written in that particular article by Ian Kurtais. And okay, they are the people who actually first described the head impulse test. And with a point that I have been telling for the last 8 years, okay, where we have been teaching people about interpreting VNG graphs and all those things, about not looking at the numbers, to look at the tracings. And the exact point, the term that is used in that particular article is tracings first, numbers next. Okay, so to emphasize the tracings, look at the tracings, not look at the numbers, and that is where actual knowledge is. Okay, so that is and next thing is, all the patients who come to us in the vestibular clinic need not have a vestibular explanation to the diagnosis. That does not absolve us of the responsibility to give them a diagnosis. So clinics have to be reoriented. Clinics have to be reoriented to cater to the patient and whatever diagnosis, underlying diagnosis they have, to pick that up, rather than, okay, we just are sticking ourselves to measuring the vestibular system, okay, and then giving a report. Okay, that is not how it should be. So an attempt towards this kind of an approach is the clinic that we have. Okay, and today, through a series of presentations, we will be actually showing what all we do when it comes to diagnosis, when it comes to treatment, management of the patient after a diagnosis has been achieved. So what we have is a series of presentations. Dr. Krupa will be telling the things about VNG, about our the way we pick up orthostatic hypotension, okay, the way we employ the fundus photography and cameras, all these things with actual clinical examples, post which I'll have Akhil, Rijesh, and also Bala to come up and make presentations when it comes to dynamic visual acuity, and also when it comes to two more things. One when it comes to the rehabilitation part, the stabilometry part, the craniocorpography part, and okay. So the highlight mainly is going to be one is of course VNG, the usual vertigo work that we do, but also some of the other things that we need to do so that our patients actually end up getting a diagnosis. Okay, we have still not reached a stage where all the patients will actually get a diagnosis in one go, but definitely the scene is much better than say what we ourselves have been doing 5 years ago, or what we ourselves have been doing 2 years ago. So it's a daily progress, and that is how it is. There is no end point or no perfection. It is always a journey. Okay, perfection is a journey. So one after the other, we start what we could not pick up last year. That diagnosis we are picking up now this year because of improved algorithms that we are following, more meticulous employment of those algorithms. Okay, so like that, and sure, next year is going to be better than this year. The diagnosis that we are not able to pick up, the patients whom we are not able to address today with what we know, maybe we will be able to do it next year and a few years down the line, because this journey has to continue. With that, I will request Krupa to come and make her presentation on optimizing outcomes. Yes, Dr.
Okay,
Krupa.
Okay, sir. So good evening, a very good evening to one and all. At the outset, first, I would like to take blessings of my Guru, Dr. Srinivas sir, and thank him for allowing all of us and giving us this opportunity to present our work on this platform. So having said that, is my screen visible?
We are able to see Dr. Krupa. You can carry on.
Yes.
We can see.
So today's topic, so as sir has already given a excellent intro about, how can we optimize outcomes in our clinic. So without wasting any further time, I'll proceed to the first case. So this was a 76-year-old female who came to us somewhere last year with complaints of rotatory vertigo. And, especially it was while she was turning in bed and looking up and down. So we were dealing with a positional nystagmus here. Although there were no migraine triggers in her or any vascular risk factors, after a clinical ENT examination and otoneurological examination, when Dixolpike was clinically performed, it was negative. We proceeded in this case with the VNG as we do. And that was the VNG graph, which was seen in her, no baseline nystagmus. The first time that we did, this was the very first time we did, which showed a left beating nystagmus. But, it was not conclusive of, like, there was no vertical component in this one. We were thinking because she was clearly saying that it is on looking up and down. And there was also no reversal on getting up. Again, one more maneuver was done in her case on VNG, which didn't show any findings. So, but the patient kept telling that, there is positional nystagmus. She was giving a very strong history, which made us to believe that, there's no harm in repeating a third time, the same maneuver, Dixolpike, for another time. And the patient was having said that the patient was not on any vestibular sedatives at that time, which could, mask the nystagmus, underlying nystagmus. So what happened after the third maneuver? Let us see. Yes. So we can classically see left beat, the torsional nystagmus with the upper pole beating to the left. So we were dealing with the left posterior canal BPPV here. That is when the patient was brought up in the sitting position. You can see a few downbeats there. So there was also reversal. This was the graph which we got on the third attempt, which was an hour later. So nystagmus here and nystagmus there. So point I want to stress here is sometimes we do a positional maneuver and we don't get a nystagmus. So many of us face there are many patients out there and many doctors rather tell us that, I didn't get a nystagmus, we did Dixolpide, so probably there's no BPPV. So it need not be that way. Sometimes a repeat second or third maneuver is which actually unmasks or clenches to the diagnosis in these patients. One possible explanation for this kind of a presentation could be that the debris actually started moving or mobilizing with repeated maneuvering. Also, the importance of a check maneuver is very important to rather, be sure of what a therapeutic maneuver you have given in these patients and the credibility of your maneuver. So, that is how we could pick up it in the third attempt. Moving on to the second case. Now, this was a 32-year-old male with a history of true rotatory vertigo for lasting for a few seconds only. There were no typical migraine triggers, but the only thing positive in him is an occasional motion sickness and a history of his mother having headaches. So, of course, when after ENT and otoneurological clinical examination, this was in VNG on gaze test without fixation. This is the kind of rebound nystagmus that we got in him. You can see that in gaze without fixation on the left side there is left beating nystagmus, and when the patient looks back to the center, that was the rebound nystagmus underlying, which we were able to show in this particular patient. So although many VNG systems out there, like I speak to people and I've come to know that not every VNG system out there has a gaze protocol. That too, the importance of doing it without fixation is a must. And rebound nystagmus, once it is there in the VNG, it points to an underlying vestibular migraine, which might not be a very sensitive test, but in the cases in which it is found, it is more so than not vestibular migraine, and it is a very specific finding. So that is what we learned from this case. Moving on, now this was an 80-year-old female who came to us with the complaints of imbalance while walking for the past 3 years and a huge number of falls, multiple falls, over 30 in the last 1 year. So of course, again, any routine ENT examination was done, which was normal. On otoneurological examination, clinically, we could see that her vertical range of motion, or the vertical saccades, were affected. And this is how her VNG looked. Those are the horizontal saccades. You can see a multi-step pattern in this VNG graph. But what happened in the vertical saccades? You can see the range of the vertical saccades is grossly reduced, if I can say that. And we found a saccadic smooth pursuit in her. The vertical smooth pursuit, again, range is grossly reduced. That's the video showing the same. You can see that horizontal, she's able to do, although the eyes are moving in steps. But the vertical saccades, let us see what happens here. So you can notice she is making an attempt to look superiorly, to look vertically, but the range is grossly reduced. She's unable to go beyond a certain limit. And we know that the first sign clinically, neurology friends will tell us that the first clinical sign to be picked up in this kind of things is a vertical saccades being affected. But the point, and of course, this is the optokinetic graph, which showed absolutely, again, flat graphs, no sawtooth pattern there, which is usually seen in normal patients. Now, this case, I want to bring to all of your attention that she got a diagnosis after 3 years, and the first time that she came to us, she actually came with a record file which was as big as a wedding album, probably. So point I'm trying to, bring across is that although progressive, I know it's a progressive condition, but that doesn't mean that the patient has to live with that. First of all, picking up the diagnosis and then whatever 2-3 years of life which are remaining in the patient's life can be addressed with rehabilitation in the form of muscular strengthening and addressing the postural strategies. And even if we are able to give this patient a 6 months of quality of life, that is amazing because it's 1/6 of what is remaining of her life. So, the importance of getting a diagnosis in long-standing cases, only the family of this patient will know, and I'm sure they were relieved that day. Moving on, this was a 54-year-old gentleman who complained of imbalance and blurring of vision while walking, especially also in the dark and uneven surface. So the first thing which comes to mind is in such cases clinically would be a bilateral vestibulopathy. Let us see what was actually the case. So just I want to show you the VNG, this was spontaneous and dark, where we asked him to look in the center, up, down. You can see a very minute oscillating, eyes are oscillating there, his eyes are oscillating, but to pick up this needs a very trained eye, or rather they actually mimic natural eye movements, and forget picking this up by a naked eye. So then a funduscopy was done. This funduscopy was done by Dr. Srinivas sir. And let us see what we actually find in him. So we can pick up there is a pendular nystagmus. You can see that his fundus is actually oscillating, and that was the right side. This is the left fundus examination. So you can clearly pick up the pulsations there. And when we looked at his palate, please look carefully. If you can see, his palate is also vibrating, is pulsating. Yes, I'm sure everyone is able to see that. So we were dealing with a patient of oculopalatal tremor syndrome here, who actually presented only with a difficulty in walking. So as sir mentioned in the introduction, when sir told us that every patient coming to our clinic may not be a vestibular patient. This is a completely different diagnosis, and we can easily miss this. And that's why the importance of a fundus examination here. It should and must be an integral part of any otoneurology practitioner, especially in cases like this where the diagnosis is in doubt and patients are saying of difficulty in walking and things like that. Final case, a 40-year-old female presented to our center with loss of balance and confidence while walking, especially at a faster pace over the last 5 years, and she had associated blurring of vision while walking. Now we know that a predominant difficulty in walking can be many other things, like the last patient. Let us see what was the diagnosis in her, right? An orthostatic hypotension, many other things. Acoustic neuroma, let us see what was the diagnosis in this case. So having said that, first thing I want to introduce you to a per rotatory nystagmus, the peaking that you see here, that we routinely do a chair rotation test in our clinic. And every time the chair turns to the right, that is the right beating nystagmus there. Okay, and we see at the per rotatory component, the post rotation, what happens, post rotatory component to the right, to the left, and something known as a VOR suppression, where the patient is given his thumb and he's asked to look at his thumb, and a VNG guided chair rotation test is done. So the graph below, yeah, so the graph below shows me, shows her chair rotation test result. This was on vision, when vision was allowed to this patient. You can see that the very prominent per rotatory nystagmus is not there in her. A very less is there because her eyes are open. But when vision was denied to her, you can see that it is almost a flat graph. There is no rotatory component or anything of like that. You know, the two peaks that you saw in the previous first graph, the graph which was above, it is not there here. And if there is no VOR, what is there to suppress? So again, a completely flat graph on VOR suppression. Now, I will never forget this case because I was new to Cyclops. I had recently joined when this patient came to us, and I was, very newly I had started doing chair rotation test. And I was not getting a response as her. This graph, which is the second graph, which is below here, which I did it for the third time in her, and I was not getting a response. And I was thinking, like, why am I not getting a rotatory nystagmus? And where are the two peaks, which are classically seen in other patients? And what happened is Srinivas sir happened to walk in the clinic, and he told me, for all you know, and I told him, sir, is there anything which I'm doing wrong in my technique, or what is happening here? And he just told me one thing, what if the viewer is not there? Have you thought about that? And he just went, and that clenched to the diagnosis. Yes, this was a case of bilateral vestibulopathy. Later, it was confirmed with the help of caloric test with DVA, which showed which showed loss in all the canal planes. Bala Vignesh will be speaking on that shortly, and a very minimal or absent bilateral caloric response in this case. So again, a simple VNG guided chair rotation test will take exactly 5 minutes for all the three protocols combined to do. But see this kind of diagnosis, which is easily missed in any vestibular clinic also, for that matter. That too, when the patient is just 40-year-old, we don't think of things like this. So this is what I want to tell you. I wanted to tell you with this case. So I hope the message is very clear out there. And last but not the least, the importance of reviewing prescriptions, previous prescriptions of the patient. Our patients, we very well know, come after meeting lot of specialists. So a thorough drug review, because we know many times drugs can only be either a drug duplication or multi-drug prescriptions. And more so because our patients are all geriatric population. So they'll be on a anti-hypertensive and anti-diabetic and anti-lipidemic. Male patients can be on alpha blockers. So things like that, So always look for a drug. Always do a drug check before you send the patient out of your clinic. Look for multi-drug prescriptions and drug duplication. So with that, again, I would like to express my sincere gratitude to Dr. Srinivas sir and our clinical team back home at Cyclops. Thank you, Bala, Akhil, and Rajesh, for being such a wonderful team. Thank you.
Okay, thanks, Dr. Krupa. I think who's going to come next? Is it Bala or is it Akhil and Rajesh? Hello.
Hello, sir. I will present.
Yes, Akhil, please. Okay, thank you. Meanwhile, I think there is a message from Dr. Ekamba Reddy. Okay, so thank you very much. So, sir says very good presentation, Dr. Krupa. And what was the diagnosis in case 3? Missed that. Okay, Dr. Krupa. Hello.
Sir.
Ekamba Reddy sir wants to know the case diagnosis in
case sir, so the diagnosis in case number 3, I think
he's talking about PSP. PSP.
Sir, it was
progressive
progressive. Yes, sir.
Supranuclear.
Yes, sir. Vertical saccades were affected. Yes, sir.
Okay, and Dr. Sirisha says a good presentation, Dr. Krupa. Okay, thank you, sirs. Okay, so Akhil, you can proceed. Thank you.
Okay, then.
Thank you. You can go to presentation mode, Akhil. Yeah.
Good evening, all. Myself, Akhil. Today, I am going to talk the importance of BP taking in patients. Patients who have gone through multiple multiple physicians for consultation, and the one important thing actually missed the diagnosis was pulse and blood pressure. In our clinic, we are following a BP protocol. The first step is to take the pulse and blood pressure on the sitting position. That's the first step. Then the second step is to take the pulse and blood pressure on the lying down position. Lying down position. And the next third step is to take the pulse and blood pressure immediately after standing. Immediately after standing. Then the next step is to take the blood pulse and blood pressure after 3 minutes, 5 minutes, and 10 minutes. So why BP taking is important? In our clinic, we are mainly focusing to rule out the open the BP. The first thing is orthostatic hypotension. It occurs within 3 minutes of standing and it is sustained. And the next is we are checking for the drop in the systolic blood pressure of 20 mm mercury and a drop in systolic blood pressure of 10 mm mercury on standing. And there is no significant increase in pulse. These are the features of orthostatic hypotension. Then move to initial orthostatic hypotension. In initial orthostatic hypotension, the fall in the blood pressure happens within 15 seconds of standing. Because of that, we are taking BP immediately after standing. It is transient and it can be missed. The drop follows systolic by 40 mm mercury and diastolic by 20 mm mercury. Then move to delayed orthostatic hypotension. Delayed orthostatic hypotension is a fall in the blood pressure happen later than 3 minutes and it is sustained. Then move to stability. Stability is the objective study of body sway during standing. It is the advanced version of Romberg test. In telemetry, in our clinic, we are mainly checking the escalating sensory denial and the escalating motor complicity. Under escalating sensory denial, 4 subtests were there. The first one is the subject has to stand on the stabilometry with the eyes open, then with eyes closed, then with the eyes open on the cushion surface and eyes closed on the cushion surface. These are the 4 subtests under the escalating sensory denial. After the testing, then the next test is escalating motor complicity. Under motor complicity, with 2 legs standing with eyes open and tandem standing with eyes open and 1 leg standing with eyes open, either left or right. Both we can do. After completing the sensory denial test and the motor complicity test, we can get the graph like this. You can see the say velocity in the motor complicity, like 2 legs standing, tandem standing, right leg standing, and left leg standing. The velocity of sway. Coming to the first, we are getting two paragraphs. One with the somatosensory and one in red color and vestibular is in black. And also you can see the stay velocity. Now we are moving to CCG, craniocorpography. CCG evaluates the functional and structural integrity of vestibular final reflex. In CCG, we are doing mainly 2 tests, Underberger test and standoff walking. to do the CCG, we need a darkroom setup and the camera which is fixed on the roof. You can see there. And the next step is the patient has to stand extra straight below the camera. That's the second thing. This is a CCG instrument with the red and blue light. According to the movement of the light, the camera will pick the movement of the direction of the subject. The software will itself generate the graph and impression. Here you can see the lateral displacement is 12 centimeters in the leftward direction. Like that, the graph will come. And you can see the rotation graph and the displacement graph. That's it. Thank you.
Thank you, Akhil. So the importance here about there are three things that Akhil covered, three investigational modalities. Of them, okay, if I have to ask the things that I like most is the BP protocol. And the blood pressure protocol is very, very important to make sure that it is always repeatable. Okay, the measurement is the same and we never get tired. See, BP measurement, actually, there is a time when, okay, you maybe at 4, 5, if you're doing 5 times, one after the other, okay, the amount of attention you give, those things are variables. So to remove the variables, it is always better that we have an apparatus and an apparatus that is reliable. Okay. Why this is important is we get lots and lots of patients. Every 2 weeks, we have one patient diagnosed with orthostatic hypotension in the clinic. Okay, sometimes it so happens that every week we get, or sometimes even back to back we get also. But overall trend is maybe every 2 weeks we get a patient of orthostatic hypotension and whose diagnosis has not been made over many months or sometimes in even years, in spite of falls, in spite of patient telling. These patients come to our clinic and they tell, what is your main problem? They tell, I'm afraid of walking. Okay, that is the kind of description some of these people actually tell. I'm afraid of walking is what they will, it's a common complaint. And orthostatic hypotension is the thing. The reason why it's a lot of time it is missed is maybe in the sitting position, they're already taking antihypertensive. In the sitting position, their BP is normal and they don't even think of anything else. It is never compared. The supine to they may actually having supine hypertension and they get up, it actually falls. That may still be within what is considered the normal range, but it is actually a fall. So, and it is not picked. And the moment that is, a lot of time it is just about skipping one medicine, little bit of modification, and their fall stop. And therefore, it becomes imperative on us to make this diagnosis. So, but the usual, if you want to really do this again and again, every time you take the usual sphygmomanometer that we have, the mercury one, and personally do that. But that is not feasible according to me all the time. Okay, so what we have started doing is I just I evaluated a lot of BP apparatus to see how reliable they are on measurements. And the usual BP apparatus that we get for 2,000, 3,000, 5,000, 6,000 rupees in the market is not good enough for that, because they themselves, their protocol is not good, because they themselves tell that don't take one reading, take 3 readings and take the average, take 3 readings and take the median value, that kind of thing. And that is not going to be good enough for us when it comes to evaluating orthostatic hypotension, because for us, every reading in orthostatic hypotension is very important. So what I did for evaluating the best BP apparatus that suits this purpose is I went to one hospital, then I went to the biomedical department in that particular hospital. I asked, I want this particular G model. Do you have a 10-year-old unit? Okay, that is the first question I asked. You have two 10-year-old units. They told, yes, so I have 2 10. Then I asked the biomedical chief to get those two 10-year-old models to the biomedical department. They just brought. What I did is 2 totally different units of the same make. I put one cuff on the right side, one cuff on the left side of myself. And then I pressed them, press the 2 BP apparatus together. I had the person to press the 2 BP apparatus together. and both of them gave the same reading with a around with a difference of 2 units. That's all. Okay, 2 or maximum 3 units. And then I repeated that not once but multiple times to make sure that two different BP apparatus of the same make, one on the right and other on the left side, again and again, is giving the same kind of reading. When that happened, I knew that this is the best model that I need to be taking for the clinic, and that is how we spent around it's 1.8 lakhs, that particular model of GE's BP apparatus. But we chose that particular thing to invest in that because of the importance of orthostatic hypotension and not missing an orthostatic hypotension diagnosis. Dr. Krupa emphasized the need to do 3 maneuvers to get a diagnosis of BPPV in some patients in whom the history is clear cut like BPPV, but then when the patient gives a negative, okay, first Dixalpike is negative, we tell, okay, the patient came with BPPV, but Dixalpike is negative, so maybe the diagnosis is something else. No, it is not like that. There are sometimes which takes the third maneuver to actually unmask the the BPPV. The reason maybe the debris is not getting mobilized for whatever reason, but then that's the finding that we are seeing. So do that. Here again, having a good, reliable blood pressure apparatus is very, very, very important, because for a human being to do the same thing on again and again, and then the speed also is there. Okay, a machine always takes the same amount of speed to do it, but when we do it with our method, the sphygmomanometer, some patients you hear the sounds very well and you can finish off the reading in 30 seconds, but when there are in some other patients it is not the case. So having a good, reliable BP apparatus is very important for orthostatic hypotension diagnosis. Then the next thing that he mentioned is about the stabilometer. One more group of patients where the diagnosis, especially bilateral vestibulopathy diagnosis, actually rests on only two things. One is demonstrating head impulse response, which is absent, or even a chair rotation response, which is absent. Ours is a clinical chair rotation protocol, or in which we demonstrate the absence of VOR in the vision denied step. There are 3 steps: vision allowed, vision denied, and the third one, VOR suppression. In the vision denied step, we are supposed to see, or clinical head impulse test that we do, or the caloric test. Sometimes we end up doing all the things to make sure. And the second one, that is the angular vestibulo-ocular reflex protocol. The next thing is vestibulospinal reflex response. And for that, we do the escalating sensory denial test. If a particular person is stable on the firm ground, if the particular person is stable with eyes open, eyes closed on a stable surface, whereas on cushion with eyes open, they are reasonably stable. On cushion with eyes closed only, they start shaking very well. Then it is a bilateral vestibulopathy diagnosis. Why this is also important? Because this you get that there at that step. The other thing that happens is people with peripheral neuropathy. We can pick it up in step 2 of the stabilometry protocol, where with eyes closed, they start shaking. A lot of patients with B12 deficiencies, these patients, we start picking them up. Okay. In fact, we have, one of the users, Dr. Sriyarsha is also there, who just told, even though the B12 actually turns out to be normal, okay, the blood B12, he actually went on because the stabilometry was actually showing that the person was having proprioceptive loss. Then he went back to this is what I had a recent conversation with him to talk to the people how can B12 be normal when in a person who's actually improving with the B12 supplementation. Then they told that this is not the exact measure. Then there are different kinds of measures of B12 to get whether there is real deficiency or not. Okay, what is routinely employed may not be the most accurate, was what the answer that he got. To that extent, these investigations are helpful in unmasking and actually tell us. When it comes to craniocorpography, it's a very recent addition into our clinic. That's again an in-house this thing. So what we did is, that's a very recent addition. Here, what happens is the patient understands, okay, what exactly is the with their eyes closed when they do the Anterburger test or the tandem protocol, and then especially the Anterburger test, when they've actually rotated, it comes as a surprise to them that the extent to which they have rotated to right or rotated to the left. Okay, when they open their eyes and they see, oh, where I am ending, where did I start and where did I end, they themselves are surprised. And this is going to be helpful when we actually do the rehabilitation. Okay, 1 month of rehabilitation, like, or 6 weeks or 8 weeks. Okay, ours is 4 weeks, 6 weeks, 8 weeks, that kind of protocol. People come 2 2 times a week for the rehabilitation protocol. So when they come and they do, and then later on, if they see a change, then it also reassures them, okay, there has been some change, there has been some improvement, because sometimes the rehabilitation changes, the improvements that happen, they're slow improvements. Okay. So when it happens gradually, patients need a measure to tell that, okay, where did I start and where am I now? Okay, so this kind of things are going to be helpful. So that is what Dr. Akhil presented to us. So thank you so much, Akhil, for presenting that work. Now I would like to request, is Rajesh coming or Bala coming?
Yes, sir, I will connect, sir. Rajesh will connect.
Okay, so Rajesh will show us the actual rehabilitation protocols that we do in the clinic. So before that, if there are some message, I'll just read the message. Dr. Dhanya says very well presented to Dr. Krupa. Dr. Pratishta says, thanks, Dr. Krupa, knowledgeable presentation. Dr. Krupa has thanked them. Dr. Shalab, very good presentation. Thank you, sir. And very good presentation, knowledge sharing, Dr. Krupa. Dr. Anjana, madam, very clear presentation on your precise presentation. Excellent presentation, Dr. Krupa. Rohiwal sir is here just next to me in the next room. Okay, we are all together here in Dubai. It's a very nice presentation, variety of cases, Dr. Krupa. And Krupa has thanked them. Dr. Patishta again, thanks Akhil, very good presentation. Please tell me normal value in stem. We'll share the normal values that are expected with you, Dr. Patishta. Okay, so then, so I think now I'll just ask I will ask Rajesh will come in and he will show you some of the rehabilitation protocols that we employ in the clinic. Over to you, Rajesh.
Yes, I will. So yeah, good evening everyone. So myself Rajesh. So here I'm going to talk about the rehabilitation purpose. So which we are following our clinic for the patient who have the difficulty in walking or standing, maintain balance programs. Okay. So this will be the balance board. I will talk about the first one. So smart balance board. So the importance of balance board is to improve the fine progressive awareness in ankle and hip. So which means the patient who have the difficulty standing or walking, they feel very difficulty in while the progressive awareness will be very less. So we'll try to improve that fine progressive awareness. So next one will be improve the postural strategies by pre-programmed patterns of movements, which means the patient will be like the resistance of the patient to prevent the fall from the fall. So we will try to improve that to improve by giving a proper physical activities. And so next one, to improve the body weight shift. So we will make the patient stand on the board. So we will do some different planes. We'll make them do on different planes, right, left, up and front. So we'll try to improve the body shifting on different planes. So that will be the smart balance board importance. So here clearly you can see the smart balance board which you are planning. So this is the balance board. This is a down part of the balance board. Clearly you can see a sensor over here. So it is connected to the system or the TV screen. So patient will be standing on this surface on the floor. So the balance board will be moving either front or back or right or left. So right or left, we can turn to opposite side. It will be moving right or left. So we'll make the patient stand on this firm surface on the balance board. So the balance board, in the sense, it will be giving it like this a game mode. So there will be a game presenting on the TV screen. I will show that. So yeah, so this will be the this is one of the patient we have in our clinic. So I will play the video here. So you can see that patient is standing on the balance board. So we can see here there is a shift on the TV screen and there's a clear red color pointer also you can see here. So the thing is, if the patient is moving front or back on the balance board, the respectively the pointer will be moving up and back. So patient task is to distract the shift by pointing the red mark on the shift or the asteroid. So when the patient is able to distract the shift, the patient will get the score. Will be going forward, patient will get more score. Will increase the level also, level 1 to 1. So it will be like that. So I will show that. So he has distracted one. So you can see it's moving front and back respectively. Yeah, it's going back. Yeah. Now front. Yeah. So same we can see both stand is here. So the thing is, the first time patient will visit that time patient will not able to do the balance board game more precisely. So he will feel very difficult to do the perform on the balance board. So the thing is, will put a harness on the patient. It will be like that. So like this, we'll put a harness on the patient and we'll hang on the patient on the both standings. So the standings will upload almost 250 kgs. So the patient will not fall. So they will feel confidence also. So the same thing we will repeat by the playing the game here. So patient can hold the harness and the standings and they can move front and back or right or left. So that will be that. So these are the different modes we have in our smart balance board. The first one is center balance front back. So it will be like patient will stand on the surface of the balance board. So patient I can move front and back and try the balance and to perform the game. Same with front and back tilt, which means on front tilt or back tilt. Same way center balance right left, which means that will be horizontal movement, right and left from center. Also right tilt and left tilt, only one direction. And also we can say diagonal movement also we can see. Which means patient will stand on the surface, the left leg will be in the front position and the right leg will be on the back position, like a diagonal plane. So they're moving a diagonal plane, left to front and right back. Same way, right to front and left back, all diagonal movement. So these are the levels we can see here: level 1, level 2, level 3. So those what will increase the level up to 2, 3, according to the patient response for the improvement. So that will be the balance board part. So the candidates who needs the balance board, which means patient who are coming for the balance board protocols mainly for post-stroke, patient who have difficulty like mean of weakness of the muscles or difficulty in like vestibular for the better vestibular for the well difficulty in standing on the uneven ground or walking, difficulty in walking, and the sarcopenia patient who are age-related muscle loss. These are the patient who are coming for the balance board mainly on the clinic. So next one is we are following a senior protocol exercise on our clinic. Like which is mainly we are focusing on the flexibility, meaning muscle flexibility. We are making the patient to do range of motion muscles like to improve the range of motion of muscles by making them do some skill activities, and so also muscle coordination to improve the muscle coordination. They are giving like the patient may able to do the right muscle movement at the right time with the right index. I mean proper index. So that's the main focus we are going to muscle coordination. Next will be muscle strengthening. So we give some physical activities to improve the muscle strengthening, like squats, push-ups, like that. So it's a same progress which follow here. I will show them. So this is arm swing. We are starting from arm swing like this. So we will make the patient stand like this. We'll make them do like this. So these are the calf raise to strengthen the calf muscle. See, patient have 2 seconds up. Then slowly coming down. Yeah. So this is the leg raise one. So we'll make the patient sit on the chair. We'll make the to do raise the leg up. Yeah. Alternately, they can right, then to left. Yes. This is a wall push-up. It's not a again, not a normal push-ups. We are making them do on a wall. Push-ups are. I can stand on the wall by pushing the wall, and yeah, take some 2 seconds on by pushing the 2 3 seconds. Then slowly come down. Yeah. So this is the arm stretches we are doing in our clinic. So patient who's having problem like while walking, while turning head to right or left, they will be benefiting a lot from this kind of exercises. So these are chairs what we are following here. Yeah, actually should be a little bit more, but yeah, it should be like that. The butt should be a little bit more towards the chair. So next one will be plank. It will be with the to do more endurance to get more endurance for the patient to make them do this one. So yeah, it's for plank also. So next one is cat and camel pose. This also we can follow. Yeah, cat and camel. Yeah. So these are short videos which are taken. This is supine lumbar stretch. Which means the patient is straight supine. Yeah. So you will stretch the hip on the alternative side, but the wrist should be on a straight position like this. You can go either side, right and left. Especially knee So yeah. And photograph also we can follow. Yeah. This is what the principles we are following here. We'll play this. So this is one of patients coming for the exercise. We show the video. This is showing. Yeah. So short videos. I combined everything in one video. Yeah. So he's doing arm stretches. Yeah. So arm stretches he's doing. Lower body and upper body we are focusing on the both sides. Yeah. So clearly you can see he could able to do that. So actually first we are doing the same protocol followed by the smart balance mode. That's actually we are following method here. So first we'll get the warm up for the balance mode. Then we'll proceed with the balance mode. So leg raise. So wall pusher. It's a brick toes. So cobra. So short videos, just a little more time, but I'm seeing like showing the short video. So it's the time limit. So next one, like this is a cognitive physical activity which you're following and this is getting a lot of benefit for the patient, like think big, act big. So in this physical activity, like they're mainly focusing like the patient to consciously enforce slow and wide side movement and to increase the base support and to restore the arm swing. So I'll be showing the video. So this is the video of the think big and act big. So you can see here the one leg, 1 second. Yeah. So the one leg, yeah, one leg will be in a static position. I mean, the right leg is static position. Yeah. So the left leg will be moved front and back alternatively with hand movement. If the right leg is going front, left hand also going front. But the left leg will be on the static position. We can do either way also. So this will be a great cognitive and effective access both patient with balance problems. So that's it for the rehabilitation method we are following your clinic. So thank you, everyone. Thank you, sir. Done, sir.
So thank you, Rijesh. So there are a lot of things that we do. See, the main part of this particular protocols of exercises is actually sitting with the elders, spending time with the elders, and making sure that they actually do them. That encouragement is very, very important. In fact, they come to the clinic for the encouragement that our boys give them each and every time that Rijesh, Akil, and Bala, and sometimes when even Dr. Krupa also takes care when she's not very busy with the diagnostic process. So, but telling these people to do them repeatedly is very important. And one is psychologically, it is very useful for them. It gives a psychological boost. In addition to that, small incremental improvements that will happen over weeks. Okay, we call them 2 times a week, and sometimes 4, 6, 8, in something like that. That we call the patients. So they come there, they go through this set of exercises. That supervision. It may be like we can give them a chart and then tell them to do. It is not going to happen. That's not going to work. Okay, they prefer, in fact, even if they are a few kilometers away, they prefer to come and actually undergo it here. Okay, that is how this is going to be helpful. And it changes the lives of a lot of senior citizens. These kind of, they are simple things, but what is important is somebody spending time with them, encouraging them, clapping. I see these boys, you come, okay, it's a pleasure to just watch them working. Okay, the way they are clapping, okay, they are encouraging each and every time. Okay, it may look like a simple exercise, okay, maintaining a calf raise. But when they do it from like yesterday, they were just not even able to manage for 1 second, and then now they are able to manage for 10 seconds, 20 seconds, the calf raise. Okay, when the feedback is given, they're really this thing. And the small incremental improvements is very important. We see patients with sarcopenia very commonly nowadays, okay, which was not being recognized before. And the sarcopenia where the muscle loss is there, it goes below. A lot of times people ask the question like, okay, this muscle has been becoming loose, becoming weak, must be happening over a decade, but why did I suddenly have problems last 1 year? The problem is that is the time when they went below the threshold where they could actually maintain a good enough balance. So strengthening the muscles is very, very important. In fact, we are dedicated one month's grand rounds for sarcopenia because that is so common. So if I have to recall what are the main things that are happening over the last few years, the things that we were previously missing and we are picking up now very much is sarcopenia, orthostatic hypotension, BPPV, which we thought is very difficult to miss. We can't really miss a BPP is what we used to think, but then now off late we have realized it is a third maneuver also sometimes which is giving the diagnosis. So like that. So these are the changes. Okay, maybe one day we will have Dr. Dhanya. Dr. Dhanya is here. She is doing a lot of good work when it comes to thiamine. That's another thing that we have been employing for a long time, but she is coming up with real good findings. Okay, in fact, she's coming up with uh, thiamine actually reversing VNG findings within 15 minutes of giving, which is huge, which she just today shared with me. So these are the kind of things. So the new discoveries that are happening for us is there are diagnoses that we always knew, but just because of the lack of a process, they are being missed. And bilateral vestibulopathy. Bilateral vestibulopathy, you will be surprised how many times, how long patients did not get a diagnosis. So these are the diagnoses. If we start picking these things up, a lot of things. So we should move away. The idea of vestibulometry is actually insight, not numbers. As long as people, okay, and the biggest thing that I have been trying to advocate people is to not look at numbers. Please don't look at numbers. Okay, numbers are useless. Okay, the idea is insight. Okay, it sometimes okay. There are some geographies where okay the demand is to show in yellow, green, and red zone the kind of abnormalities that show up, and it is easy or to put it that way, but it's not going to give any insight. Okay, we should be seeking to get insight out of what we do, the investigations that we do, and then appropriately take action. So if we simply do okay red green, so it may look nice for somebody to just show off and shrug off of their responsibility. I have done, and machine has given a certain amount of this thing. Machine has put it in green zone, machine has put it in yellow zone, machine has put it in red zone. No, that is not how it is supposed to be. It is supposed to be we human beings. Okay, so a lot of those other things nowadays, artificial intelligence will take care. We human beings will be required to make this particular what it means. Okay, this is that is very, very important. Okay, and what it means to you, to that particular patient. So vestibulometry, the purpose of vestibulometry is not numbers, it is insight. If you're not getting the insights, then there is no point in doing them. Okay, that is the point. So now the next thing, and thanks Rajesh for that presentation. What was presented today is what these people have been doing every day. Okay, so today they are presenting, but they have been doing it for more than uh, for longer than a year now with me. Okay, so thank you all. So next, I think I request. Um, okay, before that, I'll just get into the chat and see. Okay. Dr. Ramesh Roiwal, okay, so he's there just next. It will actually nice informative presentation. Pratishtha, Dr. is Brijesh is Rijesh, not Brijesh. Thank you, Dr. Pratishtha, for excellent exercise protocol. Good, Rijesh. And Dr. Ekamba Reddy, excellent physio protocols. Thank you, sir. Sir, we are calling them as a senior protocol. Okay. So now I request Bala Vignesh to come over and make his presentation on the dynamic visual acuity testing and the kinds of information that we are getting and how it is helping our patients. Yes, Bala.
Hello. Is it audible?
Yes, Bala, you're audible.
Thank you. So, one evening for I take this opportunity to thank Dr. Srinivasan for giving me this wonderful opportunity. And I extend this thanks to all the Cyclops team members for organizing the 70 Vertigo brand. Okay. So today I'm going to focus on optimizing patient outcomes in our district. Small introduction that we use this DVA when the person is moving. Okay, so we use this device with using gyro sensors in a 3D space, and we have presented the stimulus character, that is a prototype, that is a tumbling geese in all the 4 directions, and to see what was the patient's response. So overall, getting complete summary of the patient. So if at all it's a normal patients, normal individuals, what we have seen is with respect to DVA test results, we have found there was a no log mark or there was a loss of 2 log mark lines compared to the baseline. That was a finding used to see usually in terms of a normal patient. But apart from this normal patient, we have today I am going to show you 3 more patients, basically 3.
Bala, I think your network is a bit unstable. If you can work around that.
Conditions, which is more common we have seen in our particular clinic. That is a migraine patient. So what are the hello? Is it possible for everyone? Hello?
Bala, see what happened is your pattern 1, pattern 2, it was missed. So you can start off from pattern 1 again.
Okay, okay, got it. So there is pattern we have seen with respect to migraine patients. That's the pattern 1, that is no canal is involved. You can see all this 6 semicircular canal, there is a no involvement. This is how we just get an interpretation with respect to a DE. And to DE interpretation, this is the hexagonal chart you are going to get. All the 6 semicircular canals with respect to active and passive forms. So this purple circle is the response, is the patient's response. So you can see this purple responses are the patient's response. Okay, and you can see active, passive, followed by active, passive, horizontal, right posterior, left posterior, and so this purple one is the patient's response, and we have coded a color zone. So we have just go for the interpretation. If at all this response falls in this green zone, that's a normal, and if this comes within the yellow zone, we tell it's a slightly affected. You can interpret with caution. If at all the responses comes within this orange zone, that is that particular canal is inward or that side is affected. That's how we just go with this DVA thing. So first major pattern we have seen with migraine patients is that is no canal spread involved. When it comes to another part of migraine patients, that is we have seen predominant involvement of anterior canal. In anterior canal, we have seen progression of the. Here you can see this is the most common thing we see. In terms of a migraine patients, apart from the no canal involvement, you can see there is only slightly right anterior canal is involved. Okay, this is the pattern 2 to see a lot of times. We have seen the last pattern. That is the pattern 3. It is both anterior canal and posterior canal. Again, starting in migraine patients. And next, I'll just focus on a Meniere's disease patient. When it comes to Meniere's disease, with respect to right Meniere's or left Meniere's, that particular size semicircular canals are getting infected. If at all it is a right Meniere's side, right Meniere's disease, patients right anterior and right posterior canal are getting involved. Basically, same side involvement is same. In terms of a left Meniere's disease, patients left anterior and left posterior canals are missing. So what we have found with respect to menial diseases, with respect to a deviated, that is the same side involvement is seen menial disease. Then we'll focus on a vestibular paroxysmia patients. So we have seen a lot of paroxysmia patients. In vestibular paroxysmia patients, what we have seen is the first canal involvement progresses from left anterior canal. So left anterior canal is the first progression. First, it's going to get impaired is left anterior canal. Following right anterior is posterior, right posterior canal. We have usually seen all these canals are getting impaired, but most common what we have seen is left anterior semicircular canal is getting impaired in vestibular paroxysmia. So here, in terms of vestibular paroxysmia, also you can see that there is no involvement of horizontal canal. Horizontal canal is not in. So overall, with all these three, we found whatever we found in clinic is all patients' BVI is normal. There will be a response of no loss of logma, up to 2 logma scale we used to. And they have seen in a lot of findings in migraine patients, that is, it progresses from no canal involvement and involving the right anterior canal first, followed by involving other posterior canals and other side anterior canal. Okay. In terms of a menial disease, we have seen same involvement of the same side. Okay. And we have seen in my side.
Yeah, thank you very much, Bala. So, okay, and this is the work that Bala had done over a year, and there was even the normal volunteers. We went to an engineering college along with Ajit, and there was a huge study and Mayur. So we did a study to pick up the findings, like how many log marks are lost in a normal population, and up to 2 log marks lines can be lost with doing head movement in the present in even in normal people. And based on that is what we have come up with the protocol, where you see the green zone means compared to the person's own baseline visual acuity, whether it is within the 2 log marks or not. The yellow zone is the 3rd log mark loss, and the red zone is the 4th log mark loss. So that is what you are seeing in his presentation. There was some audio breakup because of internet issues, because he's in a remote location. So I'll just re-emphasize some of the points that he told. In migraine patients, what we saw is there are a lot of patients in whom there is absolutely normal. In some patients, there is a anterior canal involvement, and in some patients, if the right anterior canal, in addition to one side anterior canal, opposite side posterior canal, like one plane involvement, and then it proceeds to the opposite, the other side anterior canal involvement. This kind of thing. So maybe we thought, okay, is that it's a progressive problem where it begins with no canal involvement, then it goes on to involve the anterior canals on one side first, then it goes on to involve the entire plane, that anterior and this posterior next, and then it goes on to involve the next vertical plane, and the horizontal is always paired. Okay, so possibly, we don't know, because this has been a limited number of patients, and we don't know whether it holds good when we increase the sample size, but then this is a good way to start off, where maybe it is that kind of progress. Okay, it's hazardous to guess, okay, make big extrapolations at this stage, but then we can keep in mind that is one possibility, where maybe that is how we need to look at these patients. Maybe tomorrow we will be able to tell how people have been progressing. If somebody starts off with 2 anterior canals involvement and one side posterior canal, maybe it's very it's more severe migraine, and then when they start responding to treatment, if it starts becoming normalizing, then there has been an improvement, maybe like that. Okay, but I want to put the caveat that with the kind of sample size that we began, maybe it's hazardous to make a lot of assumptions, but maybe that is one way in which we can see future findings of dynamic visual acuity in the days to come. So that is what this thing. Okay, so okay. So Dr. Ramesh Lohiwal again says, very nice webinar. Congratulations to the entire team. Okay. Then Dr. Shalab again, excellent presentations. And we have a small structured video for rehab. We did it in the workshop, but did not have a recorded short videos. Okay, Bala can switch off the camera studies. So we do have small structured videos. In fact, we can share them in the next AMBD course that we did after the course that I mean, what in the course we did have that video. We and of course I don't know whether it is one structured video or multiple short videos. We can make one structured video and give it to you. So that's a good suggestion, and we can give that. So Dr. Dhania says informative presentation. Bala, good presentation. Akhil and Rijesh. And thank you, Dhania and Bala, Vignesh. I want to add one more addition test. Vibra Sense. Okay. Yeah, Vibra Sense is one more thing that we are using. We didn't show you today. So that is one more thing.
I just want to mention that.
Yeah. So maybe we can one day have a we can have a presentation on Vibra Sense one day with the kind of cases that we are doing. So for the proprioceptive loss, we are actually having a device called Vibra Sense. Okay. Then when Sayan was with us, he used to do a lot of Vibra Sense. So that is why he pointed that to us. Okay. Then thanks, Bala, for the informative presentation. Dr. Pratishtha, Dr. Shalab Rastogi is again telling Bala is great. His energy is infectious. Good presentation. Akhil, Rijesh, Bala. Great effort, Cyclops team. Dr. Firoz Khan, congratulations. I'm Dr. Firoz Khan, ENT specialist in Dubai. I want to learn from you all. Dr. Firoz Khan, we are in Dubai. We are in the ME Auto. Maybe we can meet tomorrow. Okay, we are here. Dr. Amish Bala, excellent. Dr. Shirisha, good presentation, Cyclops team. There are no questions here. Okay, few suggestions are there and we'll take them up. There are no questions here. So if there are questions, we can take them up. Otherwise, we'll call it a day. Dr. Firoz Khan, we have a stall in ME Auto. Maybe you can tomorrow walk. We can say hi. We'll be around. Okay. So waiting to see you tomorrow. Okay. Yeah. Any questions are there? So if there are no more questions, okay, then we will call it a day. Okay, I think most of the summarization has been happening from the after each presentation. I'm not sure in India, maybe it is later, late night now. So here in Dubai, it is 8:12, 1.5 hours later, 9:30, 9:40. Okay, so that's it. And I think Dr. Ramesh Waiwal has one more. Okay. Oh, Dr. Firoz Khan was there at Cyclops stall today. Okay. So please tell me regarding muscle loss due to atorvastatin. Muscle loss due to atorvastatin, even I have to read up. Okay, okay. We know that some of these drugs are known to cause sarcopenia, but okay, specific to atorvastatin, I think I'll have to do some more reading. Then both of us can read together, and we will do that. Okay, ma'am. So with that, any more questions? Yeah. So I think we will call it a day. So thank you all. Thank you so much. Thank you so much. Okay. Thank you all.
Thank you, sir.
And thanks for the team. Thank you, Dr. Krupa, for the excellent work, Dr. And guiding the team in making this presentation. Thank you all. Thank you so much. Okay.
Thank you, sir.
Thank you, sir. Thank you.
Thank you all.